Oropharyngeal, laryngeal, head and neck cancer, all these patients. Same thing, have a lot of speech problems, motor problems, and swallowing problems. Anyone, interestingly enough, that's been intubated for a prolonged period. Some of you may have some experience in the absence of these other problems, somehow aren't able to phonate and swallow after this intubation period. The tracheostomy tube itself in some patients has been shown to disrupt swallowing function, and certainly medications. And what's interesting here is any of these patients can be trached, but these are windows into what is swallowing all about, because why is it disrupted? And it's not so clear in the tracheostomy patients and the prolonged intubated patients as it is in the neuromuscular. This is a diagram, and as I keep reverting back to how I came to where I am today, when I would explain to patients, as many of you may have, why their loved one or even themselves aren't going to be allowed to have anything to drink, or they're not going to be allowed to eat, or we think there should be a tube placed in their stomach, and you draw a diagram or show them a diagram, and you show the close proximity here between the airway and the esophagus. And the truth is, this diagram, the way it's drawn here, it appears that this is also an open tube, the esophagus, when in fact that's a collapsed tube. So the situation you have here is an open airway and a collapsed entry into the alimentary tract. And when I show that to patients and families and how easy it is for something to go this way, and even more likely in some cases than this way, literally patients and families have said, now why would God do that? It looks like a bad design, doesn't it? And I started to wonder myself. And I started to think that, possibly this close proximity is for a reason, that these two systems are close together and interact together because they work together, and we just don't know how or why. So what I'm going to attempt to do today is explain to you why I research with one valve over others, and why I would encourage anyone else that would engage in some to follow suit, and to try to offer explanations for what does airflow do. Does it matter? So normal swallowing itself is not only awfully fast and efficient, but you have a dynamic system that's managing a dynamic stimulus. The bolus won't stay put, so it's kind of double trouble. Excuse me here. In your handout, you'll see 4 phases of swallowing. And that's pretty much convention. But in 1983, Leopold, and it may be referenced, suggested 5 phases of swallowing. And the first true phase of swallowing being an anticipatory phase, meaning before you put anything in your mouth, motor decisions are being made. And that would use the cortex and other modalities of sensory input. And I think as therapists, that's a very, very important step. And I think some evidence for that is, have you ever been surprised by something you put in your mouth? I think that's strong evidence that you had a plan, and your plan didn't match the stimulus, and you're shocked by it. If you work with Alzheimer's patients or severe head injured, you can see the absence of that anticipatory phase. And in my travels and studies, I did a year in the School of Physical Therapy at the University of Pittsburgh so that I could learn more about movement. And the same is true in locomotion. You have a plan. You're taking things in. It's not just a tactile sensory system going on. So any functions like that involve the cortex, the thinking brain that does things even though we're not aware it's thinking. And as I build this system, I want you to keep that in mind, that the cortex, we don't understand exactly what role there is. But we certainly know that if you have a stroke or something, it affects swallow function. You still have a swallow. Have you had a patient ever that the family says, well, but they swallow? Yeah, they do, but there's something wrong with the parameters or the way the swallow turns out. It's not managing the stimulus properly, even though it's present. So the notion of swallowing as a reflex, I think, is something that we need to give up, because it's not a simple reflex. And there's a lot more going on. And even airway protection, I think that the larynx is doing a lot more than getting out of the way when we swallow. So if we think of swallowing as an interactive network, we might understand a little better about what's going on in this system. And if we continue to consider that peripheral afferent information, what you see, smell, taste, what you're thinking about, all comes into play. Then there's brainstem processing. I'm going to throw one out to you if you're not familiar. There are things called central pattern generators, or areas that generate a pattern or a sequence of movement. This is true in locomotion. That's why you can walk and you can do funny things and dance, but you won't fall over, because the sequence and all this information is being reliably generated by the brainstem. The same is true in swallowing. They found bilateral brainstem pattern generators. So the pattern is reliably generated. So you have a swallow. But going back to the cortical, you need more than that. It's not just do this in this sequence. It's this long with this amount of strength, coordinating all the structures involved in swallowing. So there's a pattern overlay that goes on to that. There's information that goes on to that pattern. And then finally, activation of nerves and muscles, assuming, or if possible, that the nerves and muscles are functional or functioning properly. So I think you can see how complex, incredibly complex this system is. Now, some recent studies are starting to shed more light on this, and I like this one by Gay, and he concluded that swallowing is a highly complex, adaptive, and that's an important word, motor activity that probably relies more on higher level control mechanisms than previously believed. It's not a lower level reflex. And I think that's something important, that we continue to pursue what is going on and how do we know how to swallow, basically, in many regards. Another study by Maddock, he found laryngeal closure, and here's key to me because I'm studying the larynx, during swallowing could be modulated by peripheral conditions through the activation of afferent fibers originating, and this I like, in the oral cavity, pharynx, and larynx. So there's evidence that when they do studies and they're stimulating in the brain and in the brainstem, they'll get a sound, they'll get phonation, they might get chewing, they might get disruption in respiration or breathing. All of these neurons are closely related, so the notion that there could be information sharing going on is really a worthwhile notion. Now, some of the things I say today are new, so I can't say that they're carved in stone. I'm just trying to give you a sense of where we're going and why some of these things might be working. So if you take a patient that has been intubated for a long time, why would there be a reduction in efficiency and safety of swallowing? Michael DeVita, and this is referenced there, postulated disuse atrophy. And that's a possibility, except we don't know, and this is a nice study if someone would like to do it, we don't know if people swallow less when they're intubated. So it's possible if you talk to the dentist, they'd say you'd be more likely to swallow more because you have a foreign body there. But then again, you're sucking out secretions and things like that, so maybe you're swallowing less. So we don't know if it's disuse atrophy. So the question remains, why would something placed in the airway have any effect on the rest of this system? And when you look down here, it really looks quite remote. But when I draw swallowing anatomy now, when I explain to a family, I include the cortex, the brainstem, the airway, all of these structures, because I think this is true swallowing anatomy. Anyway, patients that are intubated, and I'll go over some of the mechanisms, they're also heavily sedated at times, taking several drugs, so there's many, many factors that can influence movement, let alone the tube itself. It can not only increase the risk of aspiration, but certainly result in aspiration, as many of us know. And interestingly enough, even after they're intubated, it's been shown to persist for a few weeks. And not in all cases, but we don't understand the mechanism of why this happens. So in swallowing function, one of the things that we do know that we need is for the larynx to elevate far enough and long enough, up and out of the way. But I think there might be some information going on first. Certainly, the trach procedure itself can anchor the airway, and I like people to try this. Place your finger on your neck and put a little downward pressure, and now swallow. It's miserable. It's just not right. I encourage you to look and see how the trach procedure was done, because there's a difference in a horizontal and a vertical incision. There's one procedure called the Bjork procedure where they suture the trachea to the skin. So not only the mechanical tethering possibly of the tube and all the ventilator equipment, but the surgery itself. If it's under a ring and they didn't do a window through the ring, these things can disrupt that mechanism. Reduced airway closure has been shown. Sasaki has found in dog models that the longer the dogs were trach, the more sluggish the vocal cords were. So this is the first hint that we've had that does the larynx need airflow to work properly? And I think that's a very possibility. And this could be why when you disrupt this airflow, reduce the airflow or something, the larynx doesn't work properly anymore. And reduced positive subglottic air pressure has been postulated and through the years. And I'm going to show you some measurements of subglottic air pressure and help you understand what it might be doing. When you do decannulate a patient, plug the trach, or place the Passy-Muir speaking valve on the end, and I'll show you why that as opposed to others, you do restore this positive pressure. One of the mechanisms that might be functioning here is that that air pressure triggers mechanoreceptors in the larynx and helps the larynx share information or processing or something that possibly started when you saw the food or something like that. So that might be the role for subglottic air pressure. Not only that, but we're starting to think that there is a reduction in sensation, not just the larynx, but the pharynx. And there's another study out, if you care to read, by Raza Shaker. And he studied a group of normals and a group of trach patients the day they were decannulated, and he put an endoscope up and watched their cords and a few other things. And he found severe disruptions in coordination between the oral phase and deglutative apnea, where you stop breathing, and closure of the cords. He found complete cord closure, unlike Sasaki. However, his patients were capped for 24 hours before his study. But even then, just that during the time he studied them, he found differences in how the larynx functioned and in coordination. And I think that adds to our thinking that not only does the larynx need airflow, but maybe the pharynx and maybe the oral cavity. Have you ever come across a ventilator patient that maybe their consult, if you're a speech pathologist, was a little late in coming, and you found them with their mouth wide open? Have you ever found that? I'm seeing heads shaking. I think that's really interesting, because why doesn't, the mouth, it seems to be sensory deprived. Why isn't it finding each other? Why doesn't it matter anymore? Because as you know, the first thing you got to do is get the mouth closed, because you can't swallow with your mouth wide open. Excuse me again. So I think that we're starting to wonder what's going on, and does this system require airflow to function properly? Not only that, but when the cuff is inflated, and certainly overinflated, and the old rule that more is better does not hold in this population. If the cuff is overinflated, it's not going to go anterior through the cartilaginous ring. It only can go back into the esophagus, so you're more likely to have impingement. That, combined with an NG tube, as you probably know, is a setup for a fistula, and very confusing for the bedside swallowy valve, because you can see plenty of good signs, yet you'll find aspiration. And being unable to generate a cough, if you can't close your cords and build up tremendous pressure to blow anything out, you certainly can't do that with a inflated cuff and a tracheostomy tube in place. So here's what we're looking at. And this would be the system that no longer, this system is different. Even though the structures are here, this system is not normally devoid of a flow of air. So possibly this is why those vent patients and these other folks don't swallow, or a new trach patient possibly does not habituate to the trach immediately. Because we do know some people do swallow with the trach in place, and that amazes me. And ventilator patients do eat. And if I could find out how they did it, if we could help those that don't seem to be able to pull it off. Anyway, reduced sensation is certainly going to result in reduced coordination. Can you imagine learning a dance and not being able to see or feel your feet? It'd be a pretty lousy dance. And I had read a study a long time ago. For whatever reason, this man had lost all sensation in his upper extremities. And needless to say, he was pretty impaired. But what they found was if he could see his hands, he tested within normal limits. So the value of sensory information I just can't put forth enough. The fact that we have taste and smell that is a neurochemical receptor system that responds to airflow also, I think, helps us in our quest for understanding what heightens sensory information in this system. So airflow can play a role. Initially, physicians conceived as a trach, and I remember this, as a solution to aspiration. And for fear I don't say it later, I'll say it now. And an inflated cuff as a guarantee against aspiration. And the truth is, the definition of aspiration is any material that goes below the vocal cords. So if it hits the cuff, it's been aspirated. You're not preventing aspiration at all. It's already been aspirated. The cuff does not prevent it. And I had called the trach companies years ago, and I had said, you know, if a patient gets pneumonia and they've been eating or drinking with the cuff up, is that a cuff failure? And they didn't want to talk to me. Tell you in a nutshell. So I think the jury's still out on that one, and I think we have a lot more evidence to the contrary, that it's better off to have the cuff down. Anyway, Nash has also found, and this is back in '88, that's not so long ago, that possibly the trach itself. So here is a window, a new insight, that, and certainly most people do believe it's sheer mechanical disruption, and those factors do play a role. So as it turns out, the frequency of occurrence is quite high, aspiration in patients, 69 to 77%, with half of ventilator-dependent patients. And here's another key, silent aspiration. Why would it be silent as opposed to the other? Could that tell us something about the sensory information this system's getting? I think it certainly can. And there's many complications due to the breakdown in normal airway defense mechanism. And more than just being able to clear the airway, I think we're showing that the system is not going to function properly. And aspiration can occur during any phase of the swallow. You can aspirate before the swallow because you lose control of the bolus. You can aspirate during the swallow because the vocal cords are sluggish and perhaps not closing. And you can aspirate after the swallow because of pharyngeal residue. So there's no easy way to know, and everyone seems to have their own pattern. And certainly silent aspiration, not sensing that there's something there to clear, or not sensing where the material is, because as I said, it's dynamic, it's going to move, and if you don't know where it is, you're not going to be able to manage it. Anyway, the effects of the overinflated cuff on the tracheostomy tube are not only mechanical, though. This is a complete robbing of airflow through the system. Here's a case. Has anyone done a bedside swallowing evaluation? I know this came up earlier. And generally, you have a nurse with you or someone, if you're a speech pathologist, and you dye your pudding blue, and you have them swallow, and they deep suction, and you go down here, and there's nothing, and they're looking pretty good. And you see a swallow, and before you know it, you start to see the material coming out the stoma. Okay, this happened to me twice. I don't fall for it anymore because I took both of these folks to x-ray and found a normal swallow. But you know what I did? I took the cuff down and I did my swallow eval because I wanted to maximize the system and get rid of any iatrogenic effects like an overinflated cuff and get any airflow through I could, and I'd find a normal swallow. So I'm fairly certain this is the mechanism. As I said earlier, it cannot herniate through these cartilaginous rings. It can only go toward the esophagus. If it's really inflated, overinflated well, it not only, the food cannot get through the esophageal lumen, so the path of least resistance becomes the larynx and the space between the tracheostomy tube and the skin. So chances are that is the mechanism, and you can do miracle cures by deflating the cuff. Now there could be other things going on, but if you know your patient, and in the two that had fooled me, they really had no reason for this type of finding. So as I was thinking about what I was going to do with these trach patients, and we'll see a video later, I switched jobs and I went to the University of Pittsburgh Medical Center, and I found on their head and neck unit that they would not allow any patients to eat until the trach was out and the stoma was closed. After all this work, I'm going to wait? I don't think. So the reason was this positive subglottic air pressure, and although no one knew the rule, there was some reports in the literature that said, gee, you take out the trach and people swallow better. So that was their plan. That was very frustrating for me, but that's something I had to live with. So it got me thinking about, well, if subglottic air pressure is what they want, maybe I can find a way to restore subglottic air pressure before the trach comes out and the stoma is closed. So I started to think about speaking valves. And I studied the valves, and the truth is that what I wanted to do was to imitate the normal system. So when we breathe in, everything's closed. You and I don't have a hole here. And when we breathe out, we still don't have leaks. And we have airflow through the upper airway. So I'm going to show you some pressure flow data, and it might look a little bit confusing, but it's really not. Okay, this is done in a patient. And this line here is flow, and I'll show you a picture of how I took this. And this line here is pressure, and this pressure is below the vocal cords. I'm measuring the pressure behind a speaking valve below the vocal cords. This particular one, and this isn't the best I have, always allowed a burst of air before it closed. Okay, so I don't think that's the normal system. This valve here, and the reason these lines are wavy, continually leaked. Even though I couldn't see it or hear it, it was flapping in the wind, basically. The mechanism of this valve is you breathe in to open it, you must exhale and maintain exhalation to close it and keep it closed. And as you can see here, airflow continues. Okay, so here's the pressure. And you know, because the vocal cords are always breaking, that's why you see that pressure. Okay, and this is the Passy-Muir. And this is what got me started, because I thought, here I've got the system I'm looking for. There is absolutely no flow, no loss of air, and here are the pressures below the vocal cords. So this is the reason I chose and continue to use this as my way of reestablishing as close as I can a normal mechanism in a tracheostomy patient. So what I had to do also was to convince them that this would have an effect on swallowing function, and I had a very fortunate incident. I had a lady with a hemilaryngectomy, vertical hemilaryngectomy, and I had her an x-ray, and she was aspirating thin liquids. And I asked if I could place the valve on, and don't do this because you're supposed to have IRB approval and all kinds of things, but I didn't know that either at the time. And you can learn from my mistakes. So I put the valve on because they hadn't been allowed where I was working, and there was no aspiration. And so I took it off, and she aspirated, and I hate to say it, I kept putting it on and off, kind of hoping. And she was a real fun lady, and I'll never forget her because she had these big pink pig slippers, and And I said, would you come over to the office and let me hook you up to this system? And she went along with it. And what I found was 10-fold increase in subglottic air pressure during the swallow. Now, the data I showed you before was breathing, but here it is during a swallow. And I was pretty excited. So here's the system that I used. And this is a speaking valve here. Okay, so this would be the end of it. This is getting airflow. Okay, so you breathe in, any flow coming out, I'll be able to sense it with a transducer. This is behind. So this is where I measured pressure, and there's 2 transducers here. There's one for flow and one for pressure. Doesn't that look really scientific? I'm really not. I just hook up these hoses, and the data comes out. So don't think that I'm some super brain. I knew what I was doing at this time. Anyway, if I'm measuring pressure here and the vocal cords are here, I have below the vocal cords or subglottic air pressure. And just to show you here, I've got flow being measured here, and I'm measuring pressure back here, so I'm below the vocal cords. Any pressures that are generated, I should be able to get. Here under video fluoroscopy is a tracheostomy patient, and as you can see here, this is clear aspiration in the airway. Now this scale here is only to 1.5, please note. This is the pressure generated during the swallow. It's a 0.5 centimeter of water. But here's the interesting thing. They continue to exhale during the swallow. You and I cannot do that unless you have a hole in your neck. So this is certainly not a normal system, and this is the condition under which aspiration occurred. Okay, same patient, same study, no time lapse between. No aspiration. This speaking valve was placed on. And this is the pressure. Look at this, scales up to 10 here. This is 9.3 centimeters of water. Look at the flow. Chances are this is how you and I swallow. And this is what I continue to study, and I think it's really fun and interesting. I mean, this could be the lingual, this pressure here could be the lingual bolus push, and this could be the subglottic air pressure. So the question now is, what's it do? We don't know, so I'm going to give you some ideas. Does it trigger mechanoreceptors that share information and give the larynx or the pharynx, possibly the oral cavity? Look at this, they've stopped breathing. Information. Does it create a physical barrier? It could do both. Or a third theory that I have some evidence for is swallowing pneumatic. Is this a pressurized system like an air gun? And just for fun, this is someone drinking 3 sips of water. You can see the pressure's going up and down, but no flow. Chances are this is what you and I are doing. And I think this is interesting. So we went on to study it, and pretty much at the same time, Rob Stackler was doing a study. I'm going to talk about this one first. This is what came out of our little experience, that the facility I was in became intensely interested in the valve and the effects that it might have. And I had fairly convinced them that if subglottic air pressure was what they wanted, that we had a way to do it faster and sooner. And that just fit right in with DRGs in today's healthcare environment. So under fluoroscopy, this study here, we took the valves on and off, and using inter-rater reliabilities and things, determined that sometimes aspiration stopped, it was reduced, but something was going on. There was a change. Rob Stackler's study here used scintigraphy, and what that does that fluoroscopy doesn't do is it quantifies the aspiration. So his wasn't guesswork like ours was. This was the real thing, and he found the same effect. There was less aspiration. And what's cute, at the end of this study, he noted that none of them would give the valve back at the end. I thought that was funny. And that just must say something about getting things back to normal. Not so with children from Angie's, but we have experience, and I think we know when things are back to normal, even though we may not know why. Anyway, going with the pneumatic theory, as I started to think about it, okay, is it a physical barrier? Airflow must play a role in sensation and coordination. When I worked in head and neck cancer, and they would remove a large part of the tongue. People didn't swallow as well. And even when the system wasn't that disrupted, I knew it was larger and people didn't do as well. So what I and many people do is ask prosthodontics to make things. But in my mind, I was making the chamber smaller because I was thinking about building up air pressure in this system. And this goes along with what I'm thinking, okay, these two systems are close together because they work together. Now, the scientific definition of a compressor or a pneumatic system is that it would have a source of input for air, okay? Most of the coordination between respiration and swallowing studies show that we like to swallow, we like to couple swallowing on the exhalatory phase. So there you are with you've got your lungs full of air, and there's a brief exhalation and then a swallow. Now when you think about it, you've got your lips closed, the velum is up, and you're injecting some air into this system possibly, because we don't have nasal emission when we swallow, right? That's not a phenomenon, and we're not losing air here. And that fits in with what a compressor would do. It would inject air, and the next thing is it would make the system smaller. It would reduce volume. And that's exactly what we do when we swallow. Okay, this could be another role for air, actually pressurizing the system. So as I'm thinking about this and going along my merry way, I went to this lecture and then found this article. This is an ultra-fast CT scan study. The difference here is when we study fluoroscopic swallowing, we're looking at a lateral view. What they were able to do was look at the horizontal slice of the bolus. And when they looked in, they saw that it was not a fluid-filled chamber. It was an air-filled chamber. And that the food itself was only taking up to, what's it say, 44%. That's not even half. And I was like this, oh man, that like buys into everything I've been thinking of. And is swallowing pneumatic? Maybe that. And I continue to put this forth. Maybe that's another role for air in this system and why you need a way to inject. And why some of the studies are anecdotally noting, gee, they swallow better. There's less residue when you take out the trach or put the Passy-Muir valve on. That's the only one that's been studied. And as I had said before, that does reflect the normal physiology because it's not leaking. Another thing I want to point out is my value of 9.3, and I continue to get in the 8 to 10 range, is the natural elastic recoil value that the lungs would give. So that's a good number. It's not an abnormal number. So if you look here, this could be another possible role, that we're taking pressurizing and that the bolus moves through not with just mechanical influences, external forces, but possibly there's an intrinsic driving force within this bolus. And you know, like plumbing, there's no peristalsis in plumbing, right? Somehow it manages to get all the way up to the building. That's air pressure. So you have to respect it. And so these are things that I think we're reaching toward. We know it works, but we don't know why. And that's what I'm very, very interested in. This is an algorithm then that came out of some of the work that I was doing there with the ENT group, where the slide doesn't look. We're right here. Rather, what they would do is if someone's aspiration was severe enough, they would do a laryngotracheal separation, and they would tie the larynx off. They wouldn't take it out like a laryngectomy, but they'd tie it off and disconnect the two systems. And they now incorporate at least this trial because we have enough evidence that maybe this is the problem. And I think we have a video now, yes we do, where my colleague Dr. Eibling will explain to you some of the history.
Hi, I'm Dr. Eibling. I'm a otolaryngologist, head and neck surgeon at the University of Pittsburgh and the VA Medical Center in Pittsburgh. I've had the opportunity to deal with quite a few patients with head and neck cancer in my career. And one of the things that become readily apparent to anyone who deals with head and neck cancer is the adverse effect of the tracheostomy on swallowing. As a matter of fact, in certain types of head and neck cancer, following surgery, we make no attempt whatsoever to feed the patient until after the tracheostomy has been removed. For example, at the University of Pittsburgh and the VA Medical Center in Pittsburgh, when we perform a supraglottic laryngectomy, the normal postoperative course consists of downsizing and removing the tracheostomy and allowing the tracheostomy